Our goal is to change the way people respond to genetic disease susceptibility. We improve people's quality of lives, I think, at a high level because we give them accurate information which covers many things, and then we support them with that information. I got involved in this field because my sister had a kid with Down syndrome. The child died after 6 days, and it was a horrific thing for a family to go through. And I couldn't believe that that could happen in this century, that we could not know until the child was born. I think if we had known, the child's life would have probably been saved, actually. Our goal with the Panorama non-invasive prenatal test was to offer something that could be used earlier in the pregnancy than anyone else in the world, and also to offer better sensitivity and specificity and coverage than anyone else in the world. And we've really achieved that goal.
I am a maternal fetal medicine specialist and medical geneticist. We are offering Panorama to all high-risk patients. This is such a great screening test that has a high accuracy that they feel confident in knowing that once those results come back low risk, that their baby is most likely unaffected. This has been a great option for those patients who want additional information but don't want to take the risk of pregnancy loss that comes with invasive testing. Many of our advanced maternal age patients are quite worried about their pregnancies. With the ability to provide them a test that's non-invasive, that is a better screening test than what we currently have to offer, we've been able to give them some reassurance earlier on in the pregnancy. When we first began, all we had was maternal age as a screen for chromosome abnormalities, and that had a terrible detection rate of roughly 50%. Since NIPT has come on the market in really 2011, we've now been able to offer patients a screening test that has a greater than 99% detection rate. The risk of a microdeletion syndrome does not increase as the maternal age increases. And some of those conditions can be very common. In fact, DiGeorge syndrome is one of the most common things that we see in terms of microdeletion syndromes. So I think it's a great test to be able to offer patients who have some findings on ultrasound or some history that would put them at risk for that condition. I think the most devastating thing for an obstetrician would be to be at the time of delivery and deliver a baby that had a problem that we didn't know about ahead of time. It's obviously devastating for the family, and it's just as hard for us to have to break that news to them at the time that's supposed to be so joyous. So I think anytime we're able to diagnose a problem early in pregnancy and give the family time to plan, what you'll find is that most of them don't choose to go with an invasive test because NIPT, and namely Panorama, is such a great test.
Thank you all so much for coming. I am Kimberly Martin, in case nobody figured that out yet. I am sorry. I'm delighted to be in Nashville. The last 2 times I came here, I actually drove. I was living in St. Louis. So I came down for the American College of Medical Genetics meeting twice. And I have to tell you, I had the best poutine ever at this little bar down near the convention center. Anybody who doesn't know what poutine is? Like French fries with gravy and cheese curds, which is a French-Canadian heart attack. And I went to McGill University for medical school. So full disclosure, not only am I a full-time employee of Natera, I'm their medical director for reproductive testing. I'm Canadian. I did all my training up in Canada. I'm an OBGYN and a clinical geneticist. But I always practiced in the States because I met and married an American, and I defected in 1993. So 22 years in the US, mainly in academic practices within divisions of maternal fetal medicine, really with an emphasis in prenatal diagnosis, ultrasound procedures, and genetic counseling. And 7 months ago, I gave up clinical practice to come on board full-time with Natera. And I have to say, I'm embarrassed to say I really haven't looked back. It's really like I have a new life. I saw cell-free DNA coming down the river on a big, big wave, and I knew it was going to radically change how we approach screening for Down syndrome and aneuploidy. In fact, I was saying to, I don't remember, Steve, Steve, I don't remember your last name. Down syndrome screening is now fixed. If women want more information non-invasively about the likelihood that they're carrying a baby with one of the common chromosome abnormalities like Down syndrome, it's fixed. And I think that is a really good thing. So with no further ado, We're going to talk about cell-free DNA. This is a technology that has doubled in terms of utilization around the world for the last 3 years. Incredibly rapid uptake, which clearly tells us that women and their providers like the technology. But I want to make sure that we're all on the same page, because it's really important to understand what cell-free DNA is. So we used to think, right, that all of our genetic information packaged in chromosomes was in the nucleus of our cells. Right? That was what I was taught in medical school, it's what we were all taught in medical school. But in fact, it was recognized decades ago that floating in the plasma are little pieces of genetic information, little pieces of chromosomes. So when a cell dies, it kind of like explodes and it releases all of its genetic information into the circulation. And these little fragments, they're cleared very rapidly. And Dennis Lowe, who's a genius, in 1997, recognized that in fact, when a mother is pregnant, about 10% of these little pieces of chromosomes floating in her bloodstream are from the placenta. Genius. So suddenly, we didn't have to rely on invasive tests like amniocentesis or chorionic villus sampling to get access to genetic information from the pregnancy. We had a non-invasive way to get access to the genetic information from the pregnancy. Now, I use the term pregnancy very carefully because initially it was called cell-free fetal DNA. In fact, it's not fetal DNA, it's released from the placenta. So we have a baby here who's in a gestational sac, and we have a placenta right here that's very intimately related to the maternal circulation. So those little pieces of DNA, in fact, are released from the placenta, and about 98% of the time, the genetic information in the placenta mirrors the genetic information in the baby. It's exactly the same. But 1 to 2% of the time, there can actually be some cells in the placenta that may have an abnormality that's not reflected in the baby, and vice versa. Rarely, the baby has a genetic abnormality that's not reflected in the placenta. We call that placental mosaicism. So any evaluation of these cell-free DNA fragments will never be completely diagnostic because of that possible inconsistency between what's in the placenta and what's in the baby. And if you don't remember anything else I say tonight, remember that no irreversible decision should ever be made based on a cell-free DNA test. Okay? It is not an amnio or a CVS. It's pretty darn close in a lot of clinical scenarios, but it's not the same. All right? So please, please remember that. Now, as I said, on average during pregnancy, about 10% of these fragments are coming from the placenta. The other 90% are coming from the mom. And the main contributors are her white blood cells and her adipose tissue. So I was told today that the state of Tennessee ranks #2 in maternal weight. Most recently, I was most recently practicing in Missouri. Well, Missouri's eating for 2. So Missouri also has a well-nourished pregnant population. So something that's very important when you're looking at cell-free DNA analysis is something called the fetal fraction, right? So the fetal fraction is the percentage of these fragments that are actually coming from the pregnancy compared to the amount of the fragments that are coming from the mother. So you read a lot about fetal fraction. So basically, fetal fraction does increase as the pregnancy goes along, although not very quickly until after 20 weeks. It's relatively consistent, goes up about 2% between 10 and 20 weeks, shoots up after 20 weeks. So you can basically, fetal fraction is affected by the size of the placenta, but it's also affected by the size of the mother. So if you have a big mom who's contributing more considerable amounts of cell-free DNA, the relative amount, right, the fetal fraction drops, okay? So I'm going to talk about fetal fraction in just a minute, but I want you to just kind of have that concept. So hopefully it's a long introduction to what cell-free DNA, but I think it's really important to just have a basic sort of understanding of the biology of what we're talking about. So I realize that there are lots of companies that sell cell-free DNA, and I'm full disclosure here. About 90% of the time, it probably doesn't even matter what product you choose. The problem is for about 10% of patients, it actually does matter what product you use. And unfortunately, you can't tell in your office who the 10% are. So what I'm going to work through over the next 10 to 15 minutes are some of the differentiators between the different products that are out there. And there's a reason why Natera's product, Panorama, is in its own little box here, right? And a reason why everybody else is in the blue box. So basically, everybody takes a blood sample, everybody spins it down and isolates the cell-free DNA from the serum. The question then is, what do they do with those cell-free fragments? So in order to have enough DNA for analysis, you have to amplify the fragments. So you have to use polymerase chain reaction, or PCR, to make more DNA. And depending on your targets for making more DNA, you can either amplify the DNA in a selective or targeted manner, or a non-selective or shotgun manner. Right? So you set the chemical reaction. You decide what portions of the DNA you want more of. Shotgun sequencing means basically you want more of everything. So you amplify the DNA in a non-specific way across all 23 pairs of chromosomes. At Natera, our focus are in things called SNPs. And a SNP is a single nucleotide polymorphism. There are millions of places in our genetic code where you and I can differ, and it has no consequence on our health. But it actually allows us to create a unique DNA fingerprint. So we differ at a single base pair. Here, this person is CG, this person is AT. It doesn't cause a problem. We're not looking for what we call mutations, but we're looking for regions in the DNA where we can differ. And of course, a baby is the product of a mother and a father. So a mother gets half its SNPs from its mom and half of its SNPs from its dad. So by definition, we choose SNPs where there's a high degree of variation within the population. This actually allows us to distinguish what's from the pregnancy and what's from the mother. And it's that ability to distinguish between mother and pregnancy that sets us apart. So once we amplify the SNPs, in fact, we look at the SNP ratios across the 5 chromosomes of interest. We specifically increase the amount of DNA for the targets that we're interested in. So we target about 14,000 SNPs, 14,000 little base pairs, distributed across what I call the big 5. 21, 13, 18, X, and Y. We then create a SNP profile. So we look at the individual allele ratios at each one of those SNPs, and we use an advanced bioinformatics program to take into consideration the frequency of crossing over, and we end up being able to make a high confidence call in over 96% of cases. As you can see, the SNP pattern clearly diverges when the fetus has trisomy, has 3 copies of a chromosome, compared to when the fetus has 2 copies of a chromosome. So we get a very clear picture. If the DNA fingerprint is too smudgy, it's a no call for us. Okay? We basically... So our fetal fraction, we actually, because we have a SNP-based algorithm and we read the DNA, we actually are robust to a fetal fraction of 2.8%. Other companies have a 4% cutoff for analytics. So ACOG SMFM released a new committee opinion in the fall, and although I think there was a lot of wishy-washiness in that committee opinion, and I certainly had to read it 3 or 4 times before I didn't understand what they were saying, they were very clear about fetal fraction and the fact that if in fact you are going to pick a laboratory for your cell-free DNA analysis, that in fact accurately measuring and reporting fetal fraction should be an important quality metric. And at Natera, we use our SNP-based technology to evaluate fetal fraction, and we report fetal fraction on every report. You don't need to call us for that. So why is fetal fraction so important? It matters for all of us. If there's very little placental DNA in the sample, if you're below that 2.8% metric for us, we can't get a clear image, okay? And we will ask for a redraw. Counting, which is what everybody else does, is particularly sensitive to fetal fraction, and I'm going to illustrate why. So what counting does, right, they increase all of the DNA in the sample. Now they may target specific chromosomes or they may target the whole genome. They basically use what we call a reference chromosome. In this example, the reference chromosome is chromosome 3, which is considerably bigger than chromosome 21. So what they look at are the relative sizes of a reference and a chromosome of interest. And they look at how much DNA, what the ratio between those two chromosomes should be if the baby is disomic. And they look at the observed ratio in the sample. So basically on the left, this bar with the green on top, that's the expected amount of DNA, green being the fetal DNA and mom's being blue, if both have 2 copies of both chromosomes. If the baby has an extra copy of chromosome 21, what you see is more fragments of chromosome 21, right? So the observed to expected is quite different. We call that a z-score in statistics. And if that z-score is at a certain threshold, usually a z-score of 3, it's considered a high risk if it's above 3, and it's considered a low risk if it's below 3. So it's a cutoff. Well, as fetal fraction falls, the ability to distinguish the difference between an affected and an unaffected pregnancy falls. And if you look at a fetal fraction of 5%, right, the difference is almost indistinguishable. So in fact, the ability of the counting method to identify Down syndrome at fetal fractions between 4 and 8% is only about 75%. Sensitivity below 8%, fetal fraction, 75%. That's a quad screen. So if you're offering cell-free DNA because of the superior sensitivity, it's helpful to know when you're talking to your patient about her results if her fetal fraction was 10%, 15%, 4.1%, right? Because the confidence if you're using a counting method is very different. Because we're SNP-based, we have a slightly higher no-call rate because we either can make a high confidence call or we can't. We don't have this arbitrary cutoff where high risk, low risk. But the people in the cutoff, right, are getting a less sensitive, robust test. So that's the major difference, and that's why fetal fraction is so critical. This is a really dirty trick. This is the Takutis study, where basically a couple of MFMs from Boston sent some blood samples from non-pregnant women to 5 laboratories. They told each laboratory that the patient was 12 weeks pregnant. 2 of the laboratories did not issue a report citing insufficient fetal fraction to evaluate the sample. One was Lab A here that sponsored the study, although I'm very sure they were blinded to the sample. And this was us. Okay, so we evaluate fetal fraction. We saw fetal fraction below 0.5%. In our laboratory, if we have a fetal fraction below 1%, it actually prompts a telephone call to the office. Because we know if our fetal fraction is less than 1%, either she's not pregnant or there's probably something serious going on with the pregnancy. Either the baby's passed away, triploidy, you see, with very low fetal fraction, so we actually call you and alert you. The other 3 labs all reported normal female. It was a normal female. The woman was a normal female. But because they don't distinguish between the fetal and the maternal DNA, they're unable to recognize that the patient's not pregnant. Now, that's fair enough because that's part of the counting method, right? It just says, is there the right amount here? And if the right amount is here, we assume unaffected. The concern was this laboratory here that actually measures fetal fraction but only reports it when asked. So you have to call and say, hey, what was the fetal fraction on my patient? They reported fetal fractions of 4% for both samples. So 4% fetal fraction with no fetus suggests that their assay for fetal fraction may not be quite as robust as we'd like it to be, because 4% is the cutoff below which they won't analyze the sample. Right? So I think that's actually the most concerning part of that study. So the other thing we're able to do is see vanishing twins. Right? So we know about 1/3 of pregnancies that start out as twins spontaneously reduce to singletons. And this was an actual case. We got a sample from a woman who'd been through IVF, and we saw a whole extra SNP haplotype. So we saw too many different SNPs that was clearly there was another fetus in the mix here. We reported it out as high risk for vanishing twin or triploidy. What we're saying when we report that out is do an ultrasound, and cell-free DNA is probably not the right test for this patient. Well, the practitioner really wanted the patient to get a cell-free DNA, so they sent it to a counting method that said, great, yeah, normal male at 13 weeks. Which was, everybody was really happy until the ultrasound 4 weeks later showed a normal female. Now in this case, the woman had been through IVF, had had 2 embryos transferred, had had an early ultrasound consistent with an early twin that spontaneously reduced down to a singleton. But what about the woman who had a little bit of bleeding at 8 to 9 weeks, you know, and then in fact that was a vanished twin, but we didn't see it with ultrasound, right? So vanishing twin, half of all miscarriages are chromosomally abnormal. So it's a definite cause of false positives, right? So if you had had a second twin that had Down syndrome that spontaneously reduced, or trisomy 18 that spontaneously reduced, we're going to see that. Counting cannot see it. The other issue is gender, right? If you had a dizygotic twin that was a different gender, not going to pick it up. Now, we're not in the business of allowing people to have gender reveal parties at the end of the first trimester. Okay, I want to make that perfectly clear, right? Yes, they do want it. But if you're going to determine the fetal sex, again, if you have a choice to choose a test that has the highest accuracy for fetal sex, why wouldn't you pick it? Okay? This is a 1.2% error bar here. So these 3 companies all have error rates between 0.5% and 1% for fetal sex. We have not had an abnormal fetal sex call when in fact we've called low risk for fetal chromosomes. And this is more than just what color to paint the room, all right? Patients become understandably upset if what they expect their baby's bottom to look like isn't what their baby's bottom looks like. And so they're either forced to have a diagnostic test, an invasive diagnostic test, or a lot of anxiety and worry through the pregnancy until, you know, the baby's born and we can do chromosomes on cord blood. The other potential cause of discrepancy are actually maternal X chromosome abnormalities. So it's usually pretty clear that a mother does or doesn't have Down syndrome. That's usually something you're going to pick up in your practice. But in fact, as women get older, we lose X chromosomes, right? And at my age, I literally feel like I'm walking the mall and I'm like, there goes another one. I'm out on the right side. I don't have Turners. I'm 5'9". I don't have a heart defect, but if you took blood from me and karyotyped me, you would probably find a not insignificant proportion of my cells are now 45X. I think it's God's way of evening the score before we all die. Anyway, between men and women, I mean. But anyway. So again, we at Natera, because we target these differences between mom and baby, if we run sort of a high pass filter to make sure that the mom has 2 copies of X, 2 13s, 2 18s, 2 21s. Right? So in fact, we make sure that there isn't an obvious maternal X issue that would lead to a high risk call for Turners or 47 XXX. 47 XXX is a chromosome abnormality that one really questions whether it's an abnormality. Not associated with birth defects. IQ is normal. Fertility is normal. Many women with mosaicism for 47XXX. We're going to pick that up and not make a high-risk call. Okay, we're going to no-call the X. We do not report maternal findings, right? But we no-call the case if we see evidence. We don't make a diagnosis, so we will not report this mother has Turner syndrome mosaicism, this mother has 47XXX. We feel that, first of all, we're not validated. Second of all, the mother is not having a test of her own chromosomes. If you have a reason to evaluate a woman's karyotype, evaluate her karyotype. But we will no call the case. We will not confound a case calling high risk for a fetus if what we're really seeing is from the mother. So the SNP difference, okay? We detect vanishing twin, fetal sex accuracy. We compare goodness of fit for the hypothesis that mom has 2 copies of all the chromosomes. We're able to go down to a fetal fraction of 2.8%, and we detect these 2 conditions. So a complete mole is a very unusual pregnancy complication where you have a great big fluffy placenta and no fetus. The chromosomes are 46XX, but they're all from the father. Counting reports that as normal female. We report that as we don't see evidence of a mother in this pregnancy, the patient needs an ultrasound. Triploidy, a whole extra set of chromosomes. Again, counting sees this as normal because there's 3 copies of everything. So all the ratios remain in balance. We see a whole extra SNP haplotype, so we're able to not only call triploidy, but parent of origin. And in fact, the reproductive implications are somewhat different. A paternal triploidy has an increased risk of persistent GTN. A maternal triploidy is actually more likely to result in a fetus that survives to term. So the bottom line is, and the sentence that I like most about the ACOG committee opinion is, basically, again, we're back to talking to everybody about everything. Go back to the 2007 ACOG committee opinion that said all women deserve to know the chance of having an affected baby and what the options are for screening and diagnostic testing. And they basically said that such a discussion should include the advisability and applicability of cell-free DNA and other screening tests. Now, insurance companies are not endorsing or advocating cell-free DNA as a first-line screen for all pregnant women, but I will tell you that Anthem Blue Cross Blue Shield amended their medical policy last summer. And I have a feeling that they have some people who can do a pretty rigorous cost-effectiveness analysis. And what they decided is that cell-free DNA is going to save them money when applied to the whole obstetrical population, compared to the traditional paradigm with the nuchal translucency, HCG, PAP, maybe another blood draw 4 weeks later. So let's look at how NIPT or cell-free DNA performs in women at various ages. And if you read the ACOG committee opinion, it actually makes a big deal about the fact that the positive predictive value, the likelihood that a high-risk cfDNA result indicates an affected fetus, is not as high in younger moms. It's absolutely true. But let's compare it to first trimester screening. We'll do that in a minute. This is our paper. We published it in late 2014. It was a mixed cohort of 30,000 patients. We looked at positive predictive values for the 4 common chromosome abnormalities, and what we found was our positive predictive values for Down syndrome and trisomy 18 were over 90%, meaning if you screened positive for trisomy 21 or trisomy 18, there was better than a 90% chance you had an affected fetus, not 100%. Lower for 13 and monosomy X. Turns out that trisomy 13 and 45X are more likely to be associated with placental mosaicism. So again, makes sense, right? That if you, even though you saw it in the placenta, it's a little less likely that it's also in the fetus. So not unexpected from a biological standpoint. Now what we saw in our study was that the positive predictive values for all chromosome abnormalities were actually very similar for women over 35 and under 35. We found an overall positive predictive value in our AMA population of 83% and 87% in our average risk population. A lot of potential explanations for this, but probably the number one is the issue of placental mosaicism. We know that those chromosome abnormalities are more common as the mother's age. There's more common as mom's age that when the chromosomes go through their pairing and splitting process, that something sticks together. Similarly, the likelihood of a second error resulting in placental mosaicism is more common in older moms. So it's not that it's not in the placenta, it is. It's whether or not it's also reflected in the fetus. And in older moms, that placental mosaicism is a little more common. So if anybody had any doubts about using cell-free DNA in all pregnant women, this study published in the New England Journal in April, I think really answers the question of should everybody who wants Down syndrome screening get cell-free DNA? And honestly, I take charges and cost out of the equation because the bottom line is what we need to offer our patients is what is the best science? What is the best test? Insurance companies are going to determine what it's worth to them to provide that technology for their providers, for their clients. So I think it's great that the Society for Maternal Fetal Medicine questioned the cost effectiveness of routine cell-free DNA compared to the status quo. I think, though, there are conflicts of interest with the status quo, right? Nuchal translucency involves an ultrasound. It involves actually a higher level ultrasound than a standard first trimester screen. So let's just look at this study which directly compared first trimester screening and cell-free DNA. 16,000 women, everybody got both a first trimester result and got a result from cell-free DNA, but only the first trimester screens were utilized for patient counseling and management. The cell-free DNA information was never released to the practitioner or to the woman. Okay? So first of all, we had 15,841 women who all had a first trimester screen. Has anybody in this room ever had to call a woman and tell her that her first trimester screen had indicated a high risk for Down syndrome? Yeah. Hopefully everybody, if you have, you are not doing very much obstetrics. So does that call, is that a fun call to make? No. And do women panic? Yes. Okay, so with first trimester screening, 12,000 of these women were under the age of 35. This was a completely unselected population. So this was a typical OB population. 884 women received a high-risk result from first trimester screening. That's 884 telephone calls, okay, to say, unfortunately, your test came back high risk, right? What do we usually say when we call that out? Don't worry. Most of the time, the baby's fine, right? And if I was a pregnant woman, I'd say, well, then why did I do this test in the first place if most of the time the baby's fine? I mean, it's kind of a bit of an oxymoron, isn't it? That we now, it's such a crappy test that in fact, before we've even reevaluated her, we've already told her, ignore the high-risk result. The irony of that really was lost on me until cell-free DNA came into business. Anyway, if those women had had cell-free DNA, 47 women would have got a phone call. So think about that in terms of the workflow in your office. 884 versus 47. Right? 840 women didn't have to be terrified because they would have had cell-free DNA. What did we give up? Well, we didn't give up anything. In fact, first trimester screening identified 80% of the Down syndrome pregnancies in that population, which is exactly what it was supposed to do. Cell-free DNA identified all 38. So not only did we reduce the number of terrified women 20-fold, we went from a detection rate of 80 to 100%. If I was offered this test or this test, I don't think there's any question. If I wanted the information, which test I would want. Right? And it's only a matter of time. As I said, Blue Cross Blue Shield has already amended their medical policy in most states in the United States and are covering average risk pregnancy. So PPVs, yes, they're a little lower for Down syndrome with 76%. That was the likelihood that a high-risk call was actually associated with Down syndrome. But the likelihood of an affected baby with Down syndrome if you have a positive first trimester screen is 3.4%. That's why we're very comfortable saying that test is almost always wrong. Right? It is almost always wrong. 96% of the time it's wrong. Only 25% of the time this was wrong. As I said, we've built a better mousetrap. We just have to get it in practice. We want to help. We realize that you're all busy. We realize you aren't given a lot of time to talk to patients about these options. We have many ways that we can try to help. We have a prenatal testing algorithm that you can actually, it's a tear-off sheet. We can customize it for your office. Goes through all the options for testing, the pros, the cons, the risks, the benefits. What I like best about it now is at the bottom, it actually gives an area where the patient checks what she wants to do. Okay? So actually documents that you had the conversation. She signs it, you sign it, scan it in the record. One of those options is, I need more information. I'm not sure what I want to do. Well, for those women, we actually offer genetic information sessions. We have 40 board-certified genetic counselors. The second thing I want you to remember from my talk is that if you actually have a patient go online and set up a genetic information session, if she comes back and tells you that she was sold a test, my email is kmartin@Natera. I want to hear about it. Right? We are not in the business with these genetic information sessions of trying to force your patient to have testing. What we're trying to do is supplement and augment what you've already done in the office with education and help her make a decision that's best for her and her family. Right? They're free. They're offered in English and Spanish. She sets it up online. We collect enough demographic information that you, in fact, will get a written summary of the conversation that was had with your patient. It is not genetic counseling. If there's a family history, a personal history, drug exposure, that patient needs to see a genetic counselor or whatever your typical pattern is for referral, and you will get a written summary. We do have a test cost estimator. The big issue here, of course, is has she met her deductible? We're trying to get a network with every insurance provider in the United States, but unfortunately, patients, I think, when they're signing up for insurance, they think this deductible is like something optional for them, which I don't understand why that's not clear. No, it means you pay it at some point over the course of a year. Unfortunately, we have an obligation to collect deductibles just like everybody else. Many people don't draw blood in their offices anymore, or perhaps they've got in-office blood draw with a lab like LabCorp or Quest who won't draw for another laboratory. We actually offer mobile phlebotomy, and your patient, if she has an order for the test, she can call, she can schedule. They'll come to her place at work, they'll come to her home. I've heard about them going to kids' soccer games, whatever is going to be convenient for her. So if you don't have mobile phlebotomy in your office and you want your patient to have Panorama, we're happy to do it. Questions? I'm going to stop for a minute because I need a drink.
How can maternal fetal defend 16,000 screens that have a 3.3% positive? And ACOG, I'm strongly against it. I'm confused because like today I am give me that finger.
I can't believe that.
It's the second finger, not the third.
Well, it's only, because of the way it's harder to, it's harder to do that. But anyway, so I think there's a lot of reasons, all right? And it's interesting that the reasons for why they're not embracing cell-free DNA, yes, so somebody just, yeah. So in many parts of the country, nuchal translucencies are really the sole domain of maternal fetal medicine practitioners. So that is a fairly large source of revenue, and that's why I said there are lots of conflicts of interest around aneuploidy screening. I'm not saying that women can't benefit from having an ultrasound between 12 and 14 weeks. What they don't need is somebody getting carpal tunnel trying to get the perfect mid-sagittal nuchal translucent. If there's any sonographers in the room, you know what I'm talking about. But it should be pretty obvious if there's 3 to 4 millimeters of fluid on the back of the neck. And if there is, that patient is no longer having screening. That patient has a finding that dramatically increases the risk for underlying fetal abnormalities. But if it's under 3 millimeters, right, you can move on and look at the fetus. I mean, anencephaly is diagnosable between 12 and 14 weeks. Limb body wall, is the liver outside, right? There are some pretty bad things that should be part of your checklist in that 12 to 14 weeks. They're also talking about education, okay? They're saying general OBGYNs don't have the ability, don't have the time to counsel women about cell-free DNA, so we're protecting women from having a test that they didn't get an informed consent for. Well, what were we doing with first trimester screening for the last 30 years? I actually think it's more straightforward to explain, we're going to take a blood sample, we're going to look at genetic information from your pregnancy, and we're going to look for 5 chromosomes, as opposed to, well, they're going to do this ultrasound, and they're going to see how much fluid's under the skin and the back of the neck, and then we're going to do some hormone levels, and basically we'll put all of that into the program and high risk, right? I mean, really? I mean, we're doing the same thing, we're adjusting risk. We're just doing it a whole lot better. So I don't believe that generalists or nurse practitioners or nurse midwives or anybody doing obstetrical care can't counsel a patient. The third thing they're talking about are all of these incidental things that get picked up when you do a first trimester screen and then the patient has an amnio. Yeah, you do find some problems. When you identify 1 in 20 women as high risk and do an amnio in every one of them, you're going to find a few things. But here's my experience. Women don't want an amnio. They don't want an invasive procedure. So in fact, what's going to happen is they're going to have cell-free DNA anyway. And cell-free DNA doesn't pick up a lot of the things that an amniocentesis can pick up. So the American College of Medical Genetics is going to reissue their position paper very soon. I understand it's going to come out the end of March. When they released their initial position statement in 2013, they did not discriminate based on age. They specifically left maternal age out. They just talked about cell-free DNA. My understanding is their new position paper is going to come out and be much firmer and saying, it's about time. Sorry, long answer to a great question. Other questions? So this little guy has something called 22q deletion, and I'm presenting this really because this is what is next. So the reality is that scientific technology is rapidly expanding, and we're now able to use those little pieces of DNA, not just to look for 5 chromosomes, but to look for other smaller, extra, or missing pieces of genetic information. And we think, in fact, that the 22q11.2 deletion syndrome may be as common in the general population as 1 in 2,000 pregnancies, which is actually a little less common than Down syndrome in 20-year-olds, but not much. And in fact, maternal age doesn't affect the incidence. It's the same across all maternal ages. And it's not often immediately recognizable. Okay? So all of the people in this montage of pictures actually have 22q11.2, but they don't all have the traditional or characteristic features. We don't know what the actual incidence is. As I said, it's probably going to end up somewhere in the 1 in 1,000 to 1 in 2,000 range. It's almost always a brand new change. So more than 90% of the time the parents are healthy, we don't have it. It's a new change in the fetus. About 10% of the time one of the parents is affected. And in fact, the manifestations can be relatively mild. So we sometimes identify parents after they get pregnant and have a more seriously affected fetus. Right? The thing with 22q is that the features are quite variable, but some of them are amenable to treatment. First of all, unfortunately, about 90% of them have some degree of developmental delay or learning difference. And some of them are quite severe, some of them are quite mild. 3/4 of them have heart defects, which may be identified prenatally, but I think, again, we may sometimes overestimate our ability to find heart defects. And the heart defect that is really pathognomonic for 22q11.2 is an interrupted aortic arch, which is very challenging to diagnose at 20 weeks. It's challenging in the 3rd trimester. And it's one of those cardiac lesions that's ductal dependent, which means if you have an undiagnosed interrupted aortic arch and you go home, day 3, day 4, day 5, and your ductus starts to close, you can have a cyanotic crisis. About half will have hypocalcemia or seizures, and this can onset as early as the 1st day of life. And there's emerging data to suggest that if you experienced hypocalcemia or seizures as a neonate, you're more likely to have a degree of intellectual disability that's in the severe range. So in fact, this may be a cause of intellectual disability that we can actually improve outcome by early recognition and treatment of the symptoms. Renal malformations, pretty common, about a 3rd, under-recognized. This is important. Cleft palate, all right, and a submucous cleft palate, relatively common with 22q11.2. But in fact, abnormal movement of the palate is even more common. And that significantly affects these kids' ability to suck, swallow, breathe, not all at the same time. So you think about the biggest challenge, right, for a mom with a new baby, feeding the baby, right? Basically, if you have a child with unrecognized velopharyngeal insufficiency, you're going to go through a lot of hoops trying to get that baby to latch and breastfeed successfully. 30% of these kids actually require a feeding tube. So early recognition and evaluation of the palate really can make a difference for that family. Particularly problematic, 25% of these kids will develop schizophrenia as a young adult. Also an important piece of information for families to understand. So 22q is amenable to prenatal screening. There are 2 products that evaluate the risk for 22q11.2, us and Sequino. Again, we do believe that our SNP-based technology has superior performance. This was our clinical experience. And in fact, we, in our validation studies, with respect to the common 3 megabase deletion, our sensitivity was actually 98% for the large deletion causing 22q. This is our clinical paper, came out last month in Ultrasound and OBGYN. We now have a screen positive rate that's almost just over 1 in 1,000, so we've improved our test performance for 22q. And the positive predictive value for 22q has gone from 18% to 40% by changes in our algorithm and reflexing for what we call high depth of read. So we believe that 22q11.2 is the next big thing. It is not recommended for routine screening in pregnancy. So in 2 of the cases, we actually identified a mother with the delusion.
With the delusion. She
Yep.
has that 22q delusion.
Correct. And we are generally able to see it when it's inherited. It's actually really easy to see it when it's with the dad because there's a whole set of SNPs that are missing. What we do if we see evidence of a parental deletion is we revise the risk to 50%. Again, we're not going to tell you which parent has it. The parents didn't sign up to be evaluated for 22q, but we do revise the risk to 1.5. So I'm going to actually stop there, I think. Dinner looks like it was pretty good. I see lots of empty plates. We really do have a full suite of reproductive products. Just like our NIPT, there's something a little unique about everything we do. I know we have some folks at that back table there who would love to tell you about all the things that we do and how special they are, and they are special. Probably the best kept secret, I think, is Anora, which is our evaluation of miscarriage. We do a SNP-based microarray for miscarriage. It's the best kept secret in our company. Happy to answer questions about that. Our carrier screening is really unsurpassed. We're now doing next generation sequencing. We go everywhere from CF only to a 274 gene panel. So we have a pretty broad array of carrier screening products. And you guys have been a really great audience. I really appreciate your attention tonight. I hope you learned a little bit and you're embracing this new technology. So thanks everybody, and happy to answer questions. Broad look across the genome isn't getting it with that product. In fact, for 22q11.2, which is the next most common deletion or duplication after the big 5, their sensitivity is about 20% compared to 85% for us. So we really believe that our platform, our technology, is set up really to be able to provide the highest sensitivity and specificity for these subchromosomal abnormalities. You know, there's been proof of concept with whole genome sequencing, right? So that's where basically you look at every base pair in your whole DNA. My husband actually, we moved to San Diego 2 weeks ago, and because my husband's taken a job with a company called Human Longevity. And believe it or not, they actually have now developed an algorithm that they can sequence your whole genome, and they can draw a 3D picture of what you will look like at the age of 20. Scary, right? So my first thought is, OMG, okay? Hollywood, Madison Avenue, people are gonna be having amnios, whole genome sequencing, what does the kid look like? Not so much. Like, I hope not, right? I would hate to think that we would ever get to that place as a society. But 10 years from now, I mean, the ability to use whole genome information to predict complex traits is going to be there. And I don't really think as a society we're ready to be able to deal with that. So I'm glad my kids are grown, and hopefully I won't try to give them too much advice when it's their time to reproduce. But, yeah.
Can you tell us just a little bit about Panorama?
Yeah, so Anora is basically, it's a microarray. So it looks for missing or extra genetic information down to about 1 megabase, so very, very small. The beauty of Anora is that because it's a DNA-based test, it doesn't require living cells, right? So, you know, 10, 15 years ago, if somebody had a miscarriage, we would send tissue for chromosomes, and 6 weeks later, you'd get a report saying didn't grow, or normal female, okay? Both of which are almost useless. So what Anora does is we just take DNA, so you send us the products of conception, and you send us a maternal blood sample. We actually look at both, so we actually rule out maternal cell contamination. In our study of 12,000 clinical cases, if we didn't use the maternal as the control, half the time, 46XX was maternal. So if you're going to look at products of conception, always make sure the lab's running MCC with it. And as I said, with Anora, it's part of it. So you get a kit. It has a little selection, little specimen container, just sterile saline inside, so you can actually send it home with the mom if she wants to let you take its course. She, you know, fishes it out, puts it in the little container. We do want a blood sample from the mom so we can run the MCC. You send it to us. We have a 5-day turnaround time. Amazing. So basically, by the time she comes back for her, you know, 2-3 week appointment post-loss, you've already got the results, so you can go over them. So saves you another visit. We run the sample once. We hang on to the specimen until we get our analysis back. If there's maternal cell contamination, we go back and re-dissect the sample to try to get a different representative sample from the pregnancy. So we'll run it twice at no additional charge. It's a great test. So the beauty is that half of all miscarriages are related to a chromosome imbalance, right? And so, you know, certainly, I mean, I talk to doctors who say, oh, you know, I don't do anything until they've had 3. And I'm sort of like, wow, like, how do you get away with that? I mean, my experience, and you're practiced for 22 years, I diagnosed a lot of miscarriages. You know, women having their second, I mean, they are distraught, and they want to know why. Why is this happening, right? And of course, if you can't tell them why, they assume it's something they did, right? Colored their hair, had sex, I mean, who knows, right? Had lunch meat or something. So the beauty of analyzing products of conception is over half the time you get to say, this was the problem, it was there from the moment the baby was conceived, this is the chance or not of it happening again. And it obviates that whole need for lupus anticoagulants and saline infusion sonograms and the whole thing. So, you know, I usually offered it on a second miscarriage to my patients. Offered it to them. particularly if they were older and their reproductive clock was ticking. But I used it really to avoid having to do the whole other work. It's a great test. And you can stock it, you can get it in your hospital. If you have a day surgery, if you have an outpatient surgery center, we're very good. We can usually work with the hospital to have the kits there. Folks who don't have that capability, you keep the kit in your office and just bring it with you to the OR. If you're doing a D&C, we just ask you to float it, take a little bit out, and put it in the specimen. Of course, it comes with a FedEx envelope. It's easy to send, and the blood tube's in there as well. Other questions?
What if you don't have a maternal blood product conception? How accurate is that?
So we'll run it, but if we get a normal female and we didn't have a maternal sample, we have to tell you. You could also send a dad sample, so we will take a cheek swab from dad as well if he wants to donate it, because again, assuming he's the father, we see his contribution, right? Just like with cell-free DNA, we see the dad's contribution reflected in the fetus. But it's optimal to have the maternal sample. Yeah. Great question. But we will run. And it's not extra. The charge is the same.